Labor analgesia has progressed from conventional technique to patient-centered, safe and effective options. I invite Dr. Suvarna K. Professor from Government Medical College, Wayanad, with keen interest in obstetric anesthesia, onto the stage to enlighten us on this topic.
Good morning all. At the outset, let me thank the organizers for this opportunity. Before I start, I want to know how many of you regularly practice labor analgesia? Can you raise hands? Only very few. Actually, in the 15 minutes to cover the entire labor analgesia is extremely difficult. I'll try to do justice to the topic. Labor analgesia, labor pain is among the most severe type of physical pain that a woman may experience during her entire lifetime. That is the importance of pain relief. Also, do you know how much the pain score during a labor? It is reported that the pain score are much higher than even a bone fracture. And there are many harmful effects of labor pain to both mother as well as the baby. It can cause many adverse effects, including the metabolic acidosis and fetal hypoxia. This all signifies that how important is to relieve the labor pain. And WHO and WFSA has emphasized that labor analgesia is a fundamental right of every parturient. History, the postgraduates must be knowing, the great Simpson started in 1847 with ether, but it got popularized once John Snow started chloroform for Queen Victoria. But even though it is highly popular in Western countries, high-income countries, it remains an unmet need in developing nations, including India. There are several constraints like larger population, infrastructure. Many factors are there. Before we go, you need to have a basic physiology. You all know the first stage, the pain is mainly visceral, and the second stage, the somatic component add up. Also, the spinal levels which need to block for the first stage is the T10 to L1. For the second stage, you have to add the S2 and S4 segments. There are several options for labor analgesia, from non-pharmacological to the pharmacological. Pharmacological is more prevalently used. It is from inhalational, systemic drugs and regional techniques. I will go through, just rush through each methods. Non-pharmacological, there is recently a renewed interest because they work by distracting the parturient, and that also give high patient satisfaction. In Western population, nearly almost 73% of women use at least one of the non-pharmacological along with the non-pharmacological, because it gives a positive impact to the overall labor experience. So the WHO and ACOG, everyone has recommended that these non-pharmacological technique may be complement to the pharmacological agents. So you can always use as an adjunct to your pharmacological agents. In this, several non-specialized and specialized techniques are there. There are more interest nowadays to the non-specialized, like relaxation, yoga, meditation, breathing techniques. Their interest is coming up more and more these days. I will move on to the pharmacological, because these are more common in our country, which we use. The earlier was the nitrous oxide in a 50-50 mixture with oxygen, because it's very easy to use, and they have got a very robust safety profile, because it doesn't affect the labor progress or the neonatal Apgar score or any outcome. But the concern was the nausea and the other greenhouse effects. Later, sevoflurane also used in a subanesthetic concentration, but the theatre pollution or the labor suit pollution was the major disadvantage. This is less popular. And several opioids are still used in our place, in our country, from morphine to the recent remifentanil. They have its own pros and cons, both the maternal and the fetal adverse effects, which are dosed and time dependent. One of these, fentanyl, still most of us use, because it is very short acting and fast to onset. It can be used as an intermittent bolus or a PCA, but a higher bolus immediately before delivery can lead to neonatal depression. Another newer agent is the remifentanil. If it is available, it's a good agent because the esterase system which metabolizes the drug, it is fully developed in the fetus, and also the drug is mainly metabolized in the plasma esterase also, in placental esterase also. So it doesn't reach much to the fetus. So the importance is remifentanil can be used as an alternative when the neuraxial technique is contraindicated. But there are some safety concerns because you need one-on-one nursing care because it can cause maternal hypoventilation, hypoxia. So always ensure adequate oxygenation and ventilation. Even safe PCA network, REMI-PCS network guidelines are set to how the monitoring standard if you are using REMI-PCA. Coming to the regional, this is the gold standard, central neuraxial analgesia, especially the lumbar epidural. That is a gold standard for pain relief during labor. Several, you can use epidural, combined spinal epidural, dural puncture epidural, even caudal, many things you can use. Most commonly used is the lumbar epidural. You should know these segments to be blocked for the first stage and second stage. It got superior efficacy and you can use it if the patient goes into for cesarean also. But the slow onset and the sometimes there is a sacral sparing for the second stage and sometimes could cause unilateral blocks also. These are the concerns. And for that, to overcome that, combined spinal epidural was invented started using. Here it has the advantages of both spinal as well as the epidural. It got a rapid onset and sacral analgesia. And the quality is better than the simple epidural. And it can be used when the request has come for the epidural analgesia in the late stage of labor. Another recent one is the dural puncture epidural. Here it is a modification of the combined spinal epidural. Here as just like a combined spinal epidural, you are putting the epidural, then put the spinal needle into the intrathecal space, but you are not giving any drug in the intrathecal space. So no direct administration, but this improves the overall quality of analgesia. How is the drug you are given through the epidural space, some amount can diffuse into the intrathecal space through the dural puncture. So it improves overall quality. So this also gives a rapid, reliable onset and for better sacral coverage also, and fewer breakthrough pain and top-up requirement. Single short spinal is less often used, but it is used when there is a failure of the epidural for the second stage or the request has come late in the second stage. So you can use a very small dose to cover just the sacral segments for second stage. Continuous spinal is uncommonly used, but as the previous speaker said, if you have accidentally punctured the dura during your epidural, you can introduce the catheter into the intrathecal space and use for continuous spinal anesthesia. What drugs and what goals? You always aim for an effective pain relief, at the same time minimize the motor block and other adverse effects. So use a combination of low dose local anesthetic with an adjuvant like opioid. You can use any local anesthetic. Recent ones are the ropivacaine and levobupivacaine because they got a reduced cardiotoxicity and lesser motor block. You may be having your own institutional protocol. On an average, you need an initial higher volume of 10 to 15 ml of a low concentration. Always go for a lower concentration, 0.0625 to 0.125% bupivacaine or levobupivacaine. And maintenance also go for a lower dose along with an opioid adjuvant, around 5 to 6 ml per hour. All the present day epidural labor analgesia are low dose regimes. That is the concept behind the walking epidural. You give a small dose intrathecally opioid and maintain with a lower dose concentration. And you can use an array of adjuvants from opioids like fentanyl, sulfonyl, whatever available. But these opioids can cause pruritus as well as nausea. There are concerns. Other non-opioid adjuvant like dexmedetomidine, clonidine, even dexamethasone, many others are useful. As per your institutional protocol, you can use. So whatever adjuvant you use, that will prolong the analgesia as per its pharmacodynamic profile. And these non-opioid adjuvant reduce the opioid side effects. And how do you maintain the analgesia? You can use either go for an intermittent bolus or a continuous infusion or a patient-controlled analgesia. And the newer or novel drug delivery systems are the computer integrated patient controlled analgesia as well as the programmed or automated intermittent epidural analgesia. I will talk about it later. So patient controlled analgesia is the basis of this is the labor pain is mainly a personalized experience. You need an individual approach. So in this, patient is the best manager of their own pain relief. So when they are given the PCA pump, the control, they get a self-control and self-esteem. That will improve the overall, give a positive experience of childbirth. That is the advantage of patient-controlled analgesia. An ideal patient-controlled analgesia, either there are demand-only patient-controlled analgesia as well as demand with a programmed infusion. Studies have shown that with the demand only, there is increased incidence of breakthrough pain as well as lower maternal satisfaction. So always go for a background infusion along with the demand. That is approximately 5 ml bolus in a 10 to 12 minute lockout interval and the same infusion rate also. Then the computer integrated patient controlled analgesia. Here a pre-programmed algorithm is used to maintain or modify the basal infusion rate. This program controls the background infusion depending on the previous hour's patient's demand. So it actually decreases the breakthrough pain and better pain scores and better maternal satisfaction. Another is the programmed or automated intermittent bolus. Here a preset bolus at timed interval is given by a programmable pump. There is no background infusion. The basis is that there is a high driving pressure in this pump. So it disperses the solution, local anesthetic solution in a more wider than the conventional infusion. So there is uniform spread within the epidural space. So longer duration, better, less breakthrough pain and better patient satisfaction with this programmed intermittent bolus. And you can use newer nerve blocks for the second stage. So I will see what are the myths and controversies, what are the newer insight into these controversies. You all heard that there is an increased rate of cesarean and instrumental delivery with your epidural. Is our epidural really the cause? What the evidences say? Actually, epidural analgesia has no statistically significant impact on the rate of cesarean. Even systematic reviews way back in 2002 itself has clearly described this. It can prolong the duration of labor by on an average by 1 hour, and the earlier studies have showed that higher incidence of instrumental delivery. But with the present day low dose infusion we use, even decrease in the instrumental delivery is reported. What about timing of epidural? Another controversial. Whether to wait for 4 centimeter dilatation, that is what we were all taught. But all the current literature says that there is no need to wait for the cervical dilatation of 4 centimeter or 5. The maternal request is a sufficient indication for pain relief in labor. And the safety of early versus late epidural is thoroughly studied in the literature, and even Cochrane database systematic reviews has clearly said that there is no clinically meaningful difference in the risk of cesarean, instrumental delivery or duration of second stage, even the neonatal outcome with early versus late initiation of epidural. In fact, there are some studies showed that the second stage is shortened with early initiation of epidural. And what about the impact on breastfeeding? Because it is always implicated that it can cause less successful breastfeeding attempts. Actually, studies fail to demonstrate a significant association, and the lactation failure may be multifactorial. Another interesting finding was that the association of maternal pyrexia with labor epidural. Actually, you notice that a modest rise in temperature, not more than 1 degree Celsius, the exact cause is unknown. It may be a sterile inflammation that is proposed that the inflammasomes are released by the epidural. And it doesn't warrant any evaluation for neonatal sepsis. The risk factors are prolonged labor, nulliparity, or prolonged rupture of membrane. So it's a truth that maternal pyrexia is associated with labor epidural, but doesn't warrant further investigation. Now, early was delayed pushing. We all know that there will be analgesia and patient may not push. So we always encourage the patient to push more and more. But the current concept is go for delayed pushing only because it decreases maternal exhaustion. So you allow the passive descent of the baby and monitor continuously during the labor. So the recent advances came up in the USG guidance for the epidural, especially for a difficult back in obese patients, and virtual reality because it is again another distraction technique. I'll take 1 minute only. And artificial intelligence, of course, coming into this field also, it can enable personalized and adaptive pain management strategy. It can monitor the real-time physiological parameters and predict the pain intensity and adjust the medication accordingly. These are all coming up in nowadays. So to summarize, labor analgesia is a fundamental right of every parturian, and neuraxial analgesia remains the gold standard technique, though you can have an array of pharmacological and non-pharmacological technique. Stick to the protocol which is used in your hospital. There are parturians' requirements and expectations are very different. So always discuss the various options in the antenatal period itself. And always you should focus on the overall quality of analgesic experience and the maternal satisfaction. Delivery of an infant into the arms of a conscious and pain-free mother is one of the most exciting and rewarding moments in medicine or in your life. The great quote by the Moyer. Thank you.
Thank you, ma'am, for updating us on current practices.